Hi, everybody. Welcome to our Ibogaine webinar. Um, it is my supreme pleasure to have both of these ladies with me. So I'm going to do a quick introduction of the women that are here to share their wisdoms. And then I'll share the format of this discussion and we will dive in, talk about Ibogaine. So first of all, we have the one and only Dr. Deborah Mash, who has so many different accolades, but the ones I'll name today are she's a neuroscientist and a lecturer and an inventor with about 4 decades of experience unlocking the secrets of the human brain. She is a leading researcher in neuroscience and brain disorders with hundreds of published studies investigating aging, addiction neurobiology, and neurodegenerative diseases. But Dr. Mash is also one of the world's leading experts in Ibogaine, and she secured the first FDA clinical trial approval in 1993 and actually discovered its active metabolite, which is called noribogaine, which we're going to talk more about today. Dr. Mash is also the co-founder of Demorex, a company dedicated to the pioneering medications that empower recovery from addictive disorders. And she's the scientific advisor for Bassé, which is our Ibogaine clinic in Mexico. Now we have Laura Shapiro, who is on the experiential side in terms of an expert in Ibogaine. She is an opioid addiction survivor who has had visited dozens and dozens of detox and treatment centers, but counts both Ibogaine and Dr. Mash as being the beings that saved her life from that addiction. She is the world's leading expert in Ibogaine admissions, having worked with several thousands of Ibogaine patients over a span of 18 years. And she shares a profoundly deep passion for helping people heal from addiction and trauma with plant medicines as the co-founder of Plant Medicine People, our company, and also the CEO and founder of Bassé Ibogaine Clinic in Mexico. Did I do okay, ladies? You guys have quite the bios. Thank you both for being here.
Thank you for inviting me today.
And thank you everybody for tuning in. We got a lot to talk about regarding Ibogaine. I want to start by just asking Dr. Mash, will you share kind of the impetus of how you got involved with this medicine? Like what called you a long time ago?
Yeah, it has been a very long journey for me, and I look back on it and it kind of I'm like, whew. But I'll take it briefly and then take it fast forward. So it was at the height of the cocaine epidemic in Miami-Dade. I had come back from Harvard Medical School where I did my fellowship at Beth Israel Hospital, and I was a new faculty member in the Department of Neurology at the University of Miami Miller School of Medicine. I actually had been working in the Alzheimer field, and I had also been working with in Parkinson's disease. So I was in the neurodegenerative disease space. And Miami gets hit with the front end of the cocaine epidemic. What do I mean? We were a premier transshipment point from South America through the Bahamian corridor. And as all this cocaine was flooding our country, we started to see the worst of it. What we had, emergency room admissions. We had cocaine-related sudden deaths. We had crack-exposed infants. We had a lot of crime and violence, and it was crazy in Miami. And we went from something that was chic and the Miami Vice episodes that you saw on television. I was watching them when I was in Boston at Harvard, to just the wreckage of families and businesses, and what a nightmare. And I had been working with the Miami-Dade Medical Examiners Department and got called into the team because people had come down from the Centers for Disease Control trying to understand why people were dying with what we thought at the time were recreational blood levels of cocaine. So I was curious. Curiosity kills the cat, and I got involved. All of a sudden, I got pulled into addiction medicine, and I had never published in the space or done any work with it. And we discovered the Miami Vice metabolite, which is called coca-ethylene, and we make national recognition. In the context of that, I start to hear about this drug from Africa that can be used to break the cycle of addiction and to help people get off of hard drugs like heroin and cocaine. And I thought, what is this? I've never heard of this. I have no idea. And Howard Lutzoff, who is credited with the seminal discovery of Ibogaine, contacted me in my group and my office in Miami, and wanted to use the work that we had done on cocaine to support his polydrug dependency patent for Ibogaine. He had already filed 4 use patents for Ibogaine, one for opioids, psychostimulants, nicotine, and alcohol use disorder. And now he was going to file one for polydrug dependency. Well, we had been working on the cocaine alcohol metabolite, so he wanted to take our research and use it to support his patent. I asked him about Ibogaine. I said, "You're the man behind Ibogaine. What is it? How does it work? What's the mechanism of action? What clinical data do you have? Is this something that should be studied in a research center?" And that was when he invited me to go to Amsterdam to see with my own eyes, where I was there with a colleague. I brought a colleague from the medical school with me because I figured, I don't want to be the only one with testimonial. I want to have somebody else to back up what I'm talking about. Let's go look at this. And all those years ago, it was the 1992, I saw this incredible transformative effect of Ibogaine. And I said, what is this drug? What is it doing? How can it reset the brain for all these years of hardcore, use of an opioid or cocaine? And you have a person who could completely spun clean and not craving and not doesn't have the need or the desire to go back out and use. I said, this is fundamental. We need to study it. And that was led me to think about active metabolites. And as if you look at studies from ancient shamanic practices, people drank reindeer urine. Why? Because the reindeers ate some of the psychoactive plants, and active metabolites, or the drug itself, would be purified and in the urine, and there you go. I don't know how they figured that out, but I brought back urine and we figured it out, that Ibogaine gets converted to an active metabolite. And there began my Ibogaine journey.
And there began the discovery of noribogaine, which I want to talk about in a moment. But Laura, before I throw it to you, I just want to offer to everybody that's listening, if you have questions as we're discussing, just put them in chat. We'll address as many of them as we can get to as we're having this dialogue. But Laura, would you describe the experience of Ibogaine from the perspective of someone who went to this medicine literally to help save your life?
Yeah, absolutely. I mean, I began such a profound experience. So it's really in a league of its own in terms of, I mean, specifically, let's talk about addiction interruption for a minute. But I had been through countless different treatment centers, from the best of the best, the worst of the worst, and everything in between. Years of methadone, years of Suboxone. And when I finally got to Ibogaine, it was like my last hope. I was just so sick and desperate to change my life. And in terms of like the perspective, like from the patient, like working with the medicine, within 45 minutes of taking it, it reset my neurochemistry back to a pre-addictive state. Literally, I could feel this like warmth coming up through my solar plexus, like this slight buzzing sensation. And my addiction was gone. The withdrawal symptoms dissipated. Like, it was literally a miracle of how it felt as somebody struggling with active opiate dependency. I mean, typically coming off of opiates, it's a grueling process to work through that. And it was just this profound experience. And then, the within 45 minutes, so the withdrawal started to dissipate, and that's when the visionary process started. And for me, it really was an intense visionary phase, but it feels like you're watching a movie screen on the back of your eyelids. So you're actually watching from a third party perspective, so you're not emotionally attached. This allows you to like view traumas in a different way and like have this different outlook on how and why things have unfolded, what has led you to this point in your life, almost in a way connecting like past, present, and future, of really like how and why, having those aha moments, and then kind of showing you practical steps of how to step out of these like active cycles and change. Yeah. Yeah. Wow. And the next morning, it was just profound. Like it literally felt like a rebirth process. I know that I saw my mother like a few weeks later. I actually went to in inpatient care, just like a rehab, to, you know, restructure and redesign my life after the treatment. And my mom came out to visit, and she said it was like the first time that she saw her daughter looking back at her in like 10, 12, 15 years, right? It was just the consciousness had come back. And like immediately the dark circles under my eyes had dissipated, and like life was back in me. So, yeah.
And your mom is here right now listening, which is like just such a incredible full circle moment. Like, yeah, thank you for sharing all of that. So then, Dr. Mash, can you describe from a scientific perspective how this is possible? You know, for a lot of people, this feels like too good to be true. I'm sure you thought the same when you heard about it. So,
100%,
yeah.
100%. I thought it, I didn't believe it the first time I heard it. I absolutely was a big skeptic. And the it's a very good question is what do we know exactly? What do we think we know, and what is the medicine really doing? I don't believe as I sit here today, and I had, you know, Ibogaine in test tubes. I had noribogaine in test tubes. We had it on the bench. You know, we've had it in animals. We've done an extensive toxicology workup with both Ibogaine and noribogaine. Of course, we have, you know, clinical information from hundreds and hundreds of patients that came through the St. Kitts Ibogaine clinic. What do we know about the drug? You know, despite the fact that we have a lot of information, there's a lot there. I want to stress that this is an investigational medicinal product. We don't know everything about the drug. Okay, with that proviso, here's what we know. The drug is we can distinguish the effects of Ibogaine from the active metabolite. Ibogaine is the oniric drug. Ibogaine is the psychedelic, but it fits in a category distinct from the other plant medicines, and LSD sits in a box by itself. Sasha Shulgin was the first to teach me that. It is, as Laura described beautifully, a waking dream state, and that's what oniric means. Oniric comes from the Greek word to dream, right? It does have that effect, as Laura again described, of allowing patients to conduct this introspection and life review disconnected from emotional fear, pain, and anxiety. The Ibogaine itself has a little bit of an effect that's similar to ketamine. It acts on a neurotransmitter system and a receptor called the NMDA receptor, which is where ketamine binds to a channel, a glutamate channel. It also has some effects on serotonin and a few other targets in the brain. But what we do know is that the visionary effects are mediated by Ibogaine. The noribogaine has a distinct polypharmacology. What does that mean? It's acting on multiple neurotransmitter systems. They include the serotonergic system. So it is a very potent SSRI like Paxil or other serotonergic antidepressants. It also acts on kappa-opioid receptors. It's a partial biased kappa agonist. What does that mean? It's tooling up the opioid system in the brain, which of course gets hijacked by drugs and alcohol. So it's helping to reset opioid tone in the brain. It's also having effect on a cholinergic system in the brain, which probably has something to do with the change between wakefulness and sleep. Again, this oniric experience. I remember when I was in Amsterdam that some of the people told me at the time, oh, this drug is a Remegen. And I thought, what Remegen? What does that mean? Well, again, when you have a lucid dream or you wake up from a lucid dream, you're in sort of this REM, non-REM state. And the shift from conscious being awake to being asleep involves a change between different neurotransmitter systems in the brain. So this seems to be activating also a cholinergic system in the brain. So those are three systems that we know about. The other important thing is that we know that all of the psychedelic medicines, all of them, turn on growth factors in the brain. But the noribogaine, the ibogaine-noribogaine connection acts on a growth factor that regulates the neurotransmitter dopamine. And this is very important because when drugs that are abused, every substance that people will abuse, whether it's nicotine, cocaine, opiates, alcohol, etc., all elevate the neurotransmitter dopamine. So when you're locked into an intractable cycle of addiction, your brain becomes deficient in its dopamine over time because you're getting an exogenous rewarding substance, but your normal rewards, the things that turn you on normally, and you can derive pleasure from, are hijacked by dope and booze, right? So this system gets knocked down. There's a deficiency, and it just gets mucked up, and the neurons get kind of sick. What's cool about this is that the noribogaine is turning on this growth factor, which we know by looking at development of the nervous system and what happens in the adult brain, that it makes the neurons plump up. So they get back to their kind of reset of being healthy dopamine neurons. And this is why some people are interested in even talking about ibogaine or noribogaine for Parkinson's disease, which is a dopamine deficiency disorder, right? The acquired disease of addiction is a dopamine deficiency disorder. So that was a lot of science. You probably have a lot of questions, and I will answer them from the chat.
Well, can I chime in there for a second too? I mean, so, with Bassé, we're also, targeting chronic pain with this too. I mean, in all of my years of, my previous clinic that I had, we were seeing not only was ibogaine eradicating like the opiate addiction for, let's say somebody was a pain patient, let's say an athlete, they never did drugs before, injure themselves, doctors write prescriptions of Oxycontin. We were seeing not only was the opiate addiction being eradicated, but most of the time, the chronic pain was drastically reduced, if not eliminated, because the more you deplete yourself of dopamine with the drugs, the more pain you feel. And how ibogaine is able to replenish those destroyed and desensitized dopamine receptors, I mean, it's pretty phenomenal for that.
And let me add to Laura's comment about chronic pain patients. So there's, of course, what we know is chemical dependency to prescription opioids that were, prescribed in a post-surgical setting or chronic pain is supposed to be used for acute pain, not for chronic pain, by the way. But what we know about pain syndromes is that there is what we call an affective component. So it's not just the pain that you feel when you cut yourself and you get the peripheral nervous system pain, but as pain evolves over time, the dopamine circuitry in the brain also gets miswired, as Laura has said. And so again, this is a mechanism that would explain why how you feel, your subjective effects about how you view pain in your body. There's pain in the brain. You experience pain when you have sadness and trauma and depression and anxiety, but that's also part of the same circuit. So it's teaching us something very fundamental about how the brain actually works.
Amazing information. Okay, I want to finish one piece of describing the way ibogaine works, and then I'm going to address some questions in chat. Correct me if I'm wrong, Dr. Mash, but as I understand it, so noribogaine is what happens when the body metabolizes it, right? It doesn't exist outside of us actually digesting ibogaine, and then it goes through our liver and metabolizes noribogaine.
That's an important.
And then I've heard basically that there are described like phases of the experience of taking ibogaine, in part because when noribogaine hits the system, the experience shifts and changes. Would one or both of you kind of chime in about what those phases are like? Laura, you talked a bit about the visionary phase, but to describe basically the different components of what ibogaine and noribogaine bring to the experience of healing.
That's a really good point, and I didn't explain that. So ibogaine is highly metabolized, and there are and it's under genetic regulation. So it goes through the liver and what we call first pass metabolism to the metabolite. So when you measure ibogaine and noribogaine in the blood of patients who take ibogaine, you can see the ibogaine come up in the bloodstream, reach a maximum concentration, and then ibogaine's cleared from the blood in mostly in about 24 hours, completely cleared. Whereas at 24 hours, noribogaine is still elevated, very high. So on day 2, 3, 4, and 5, after you take ibogaine, you still have noribogaine in your blood. And it washes out. I've actually been, the longest I've looked in the urine is out to about 3.5 weeks, just shy of 4 weeks. And you can still detect noribogaine in the urine that long after an ibogaine dose. What we were able to demonstrate in the St. Kitts study was that looking at the genetic regulation, the metabolism, which is you're a fast, slow, or intermediate metabolizer, as I explained, but you could actually time the intense visionary experience that Laura described by metabolizer status. And so some people are fast, rapid metabolizers, and they'll blow through the visionary phase and then go into a deep phase of cognitive introspection when noribogaine reaches its maximal concentration in the blood. Laura?
Yeah, and with the introspection phase, I mean, it feels like it's sorting the internal filing cabinets of your mind. It's basically shuffling information. It kind of comes in, it feels like almost like every thought you've ever had at the speed of thought, which is just fascinating to process that and sort through all of that unconscious material, helping make it conscious, bring that to light so we can look at it and process it in a different way. And then we typically see that like the noribogaine is present in the system anywhere from like 1 to 3 months afterwards, that you feel this lingering effect of it. It's a great antidepressant, great anti-anxiety. I mean, from the patient perspective, it feels like you're in the flow of life. Prior to taking ibogaine, it felt like everything was so difficult that I was constantly swimming upstream. And after taking ibogaine, especially the effects of the noribogaine, it just felt like the flow of life had opened back up for me. Like everything, it felt like this like magical essence to everything that I was doing. And, you know, basically too, after ibogaine, it really extends the neuroplasticity of the mind. So you're able to relearn new patterns and behaviors much easier as if you were a child. I mean, in terms of addiction, the reason that it's, 28-day rehabs is it takes 28 days to relearn a new pattern or behavior. And so the noribogaine just gives this really big push to change and to develop these new healthy structures, patterns, and behaviors, because left unaddressed, it will always, go back to the trauma, to the addiction. So having that proper care and support afterwards and really emphasizing, we consider it a window of opportunity while the noribogaine's in your system. And that is like, really, that's where you lay the foundation of your newfound life too.
It's extremely important. The window of neuroplasticity that's opening in the brain and the enduring effects through the ibogaine and its metabolism to noribogaine is so important for the long-term efficacy of this treatment. I can't not emphasize it enough. So where patients go after they have the ibogaine treatment and what support systems are there for them is extremely important to facilitate, take advantage of not only the addiction interruption, but also exactly what Laura said very, very well, which is this profound neuroplasticity. I like to say neurons that fire together, wire together. So by re-engaging this circuit, you're back on track. You are back on track. And you're not depressed, you're not craving, you're not, the anxiety is down. Now, as she describes, you're ready to embark on the next phase of your life and to really step in and to rewrite your own personal narrative, whether it's, changing maladaptive patterns of thought and behavior around trauma, or changing them around addiction.
So as you said that, it came to me. I remember when I worked for you at U of M, and you used to tell me, exercise your frontal lobes all the time. Yeah, because when you're engaging, you're setting yourself up for success differently. You're making different choices. You're coming from a different place.
And what you both are sharing, Laura, it reminds me of what you say a lot, is that Ibogaine is not a cure for addiction, it's a catalyst for change. And it just speaks to this incredible window of opportunity that we have to maximize, because Ibogaine doesn't do the work for us. None of the plant medicines do, but they can give us this rebirth, this experience for us to walk in the way in the world differently, and to protect this kind of newborn baby energy that comes forth after having this experience.
Yeah, I want to take that for a second, because a lot of clinics, like, make it sound like it is a cure. And, I really like to emphasize, like, it's a catalyst for change. You still have to do the work afterwards. Like, ultimately, like, this is, we all make decisions, right? This provides a solid foundation to help you, like, have the insight, the introspection. It eliminates the withdrawals. You can, have like the craving-free period, but ultimately, you have to be willing to change your life. And I really do not like that clinics tout this as a cure. There is no cure, right? And it's really important to emphasize this, because we don't want to promise false hope. We're not selling snake oil. That you have to actively participate in your recovery, in your healing, right? It's a reciprocal relationship here. But Ibogaine does give the solid foundation if you're ready to change.
Yeah.
One of my ibogonauts taught me this, and the way he put it is that Ibogaine, he was a very severe heroin dependent patient, like for multiple decades. Was on methadone maintenance when he came to me. We had difficulty finding a vein on him. I mean, the man was at the end of the road. And when he got to us, and he went on from Ibogaine to get a PhD and to just completely change his life. He passed away a few years ago from natural causes, but he taught us, he said, Ibogaine is the high dive of recovery. When you're going to go off the high dive, but when you hit the water, you still got to swim. And that saying has stuck with me. And it was Howard Lutzoff who called it an addiction interrupter. And that's what it is. And I really believe I've learned, I like to say that I have my life and my laboratory, that we had a laboratory of experimental epistemology. What does that mean? What that means is you have, theories and thoughts, and then you have experience, and you try to put them together. We learn from the patients who take Ibogaine. They tell us what this is. They tell us it's mind floss. They tell us it's a remegen. They tell us it's a potent reset. So the patients who have taken Ibogaine have really done the most to inform the knowledge base. And we want to respect that. And we also want to respect the plant. I frequently now, when I go and I give lectures in the public, maybe it's a sign of aging, I give credit to the plant, because it is Iboga that has, allowed us to share at this important time in human evolution and the rapid changes that are ongoing in our society, that we have an antidote, that we have a medicine that can bring about fundamental change in people's behavior and restore life in families.
And as usual, we have nature to thank for that. Yeah. Yeah.
I
Laura,
was going to say that me and Kat actually talk about that a lot too, of like, Ibogaine's really coming to the forefront. I mean, we see what's happening in Texas, what's happening in Arizona, right? And it's a common debate in our home. It's like, does the plant want this? Like, are we like perverting the plant, the culture, right? And we've really come to terms with the fact that, like, I believe to my core that the plant is putting this in front of us because now is the time, right? And If that was not the case, we wouldn't be in this position right now. Now, at the same time, right, there's the fine line between, you know, over harvesting, reciprocity, right? And so, Kat, I'm going to set this up. I want you to take this for a minute too. And the piece of reciprocity being so near and dear to our hearts. And, you know, all of these ibogaine clinics, like using up the supply with Bassé, we've also really set out to give back, to make sure that plants are planted for each client patient that comes through our center, and really, you know, preserving that element, because if we just take and deplete, then there's nothing left for future generations. So Kat, can I kind of set that up for you?
Well, you said it beautifully, and I would say in addition to that, you know, it's part of the core of my mission and decolonization of these medicines that we are also in partnership with a beautiful nonprofit called Bwiti Roots, with a something like 40-something generation priestess in Iboga medicine that over time is going to help us just honor the shamanic traditions that this medicine comes from, because Iboga has been worked with for thousands of years for psychospiritual work. Now, the reason why we don't work with Iboga straight up as the plant is the ibogaine is not concentrated enough to create this neuro reset that we're speaking of. That said, just as both of these women are expressing, we honor the plant and the traditions that it's come from. We're doing our best to create something that I don't think we have a model for really, which is honoring Western medical research and knowledge and shamanic traditions, and bringing them together in the best of ways to honor the intelligence and the knowledge and safety and reverence of both sides. So yeah, thank you for setting that up. I want to go to chat because there's a bunch of really great questions coming in. Samantha wants to know, does resistance or fear around the process of working with ibogaine create any problems like psychotic breaks similar to those that resistance creates with ayahuasca or psilocybin? Or does the process itself tend to bypass resistance and fear in some way? I'm going to start with this and then give it to the experts. Just I had my own experience a couple of months ago. And Samantha, because of what Dr. Mash is describing around how ibogaine works in a similar way as ketamine, there's a sort of disassociation, an observer energy with ibogaine that is not present with ayahuasca. With ayahuasca, you are all into your experience. With ibogaine, it gives a little bit of, or a lot, depending, sort of distance in the process. So you're more of the witness to some of the traumas that you've been through rather than feeling like it's a deep identification. That doesn't mean that there's never any element of resistance or fear. It's just far less common, just by the way the medicine also feels like that dreaming state. For example, what I loved about it that ayahuasca does not do is when I needed to use the bathroom and I opened my eyes, the visions would take a time out. I still had like the tracers and pretty colors, but the medicine waited until I used the bathroom and came back and closed my eyes and went back into like a dream state. And then the journey continued. So there's just a deeper element of safety because it isn't this deep identification in the process. Laura, does that do justice?
Yeah, and I mean, from like the patient perspective, it actually like feels like it's calming the nervous system. Like you can surrender, you can go deep into it, and it's much different than ayahuasca. Like ayahuasca, there's sometimes where I open my eyes and the visions are worse with ayahuasca. With ibogaine, if you open your eyes, it's
They're gone.
actually, yeah, it's gone, and you can have like a moment to gather yourself. So yeah, but
Let's put it in an adverse event profile, shall we? So of 287 people, patients of all variety with all kinds of comorbidity with various psychiatric disorders, from major depression, generalized anxiety disorder, and bipolar disorder, okay? We did not have anybody with schizophrenia. Obviously, that's a no-go with ibogaine. But we did have people on an axis 2 disability, some who had schizotypal personality disorder. We did not see one psychiatric AE, not one adverse event in our patient population. So, you know, that's an important observation. And some people talk about hallucinogen persisting disorder, rare for the other psychedelics, but that has been reported, and nothing like that have we ever seen with ibogaine. Now, Some of the clinics you may hear about are doing some practices which I really am strongly against. And that is to combine in the short amount of time after you've used Ibogaine to bring on another powerful psychedelic. And one of the examples that we're hearing from other groups is that they are using 5-methoxy, the God molecule, shortly after Ibogaine. That to me is just on first, second, and third principles a no-go. I don't understand. There's no rationale for this. Why would we be giving patients a whiteout experience? You've already got a complete window of neuroplasticity. You've still got noribogaine acting in the brain, and we know that the pharmacodynamic effects, what does that mean? The effects that are still going on in the brain after the drugs have left the bloodstream are in full gear. Why would you bring on another drug? And there's a psychedelic or otherwise. So you want to, these mechanisms that are ongoing in the brain, we don't completely know. We are learning. We don't have all of that information. And the rationale to do this now is not, to my mind, scientifically, clinically, or otherwise, is simply not there. So, if someone, these molecules, the DMT series of drugs, and 5-methoxy is going through clinical trials now with GH Research and also, of course, with Beckley Psytech. And more information will be revealed as those studies come forward. But, to do an experiment like this with patients, I don't think it's ethical, I don't think it's moral, and I don't think it's medically sound. So there I am, my soapbox. There I am.
I'm on the soapbox with you. I really think the only justification is because people get attached in our culture to having the big psychedelic experience. And it's just this kind of distorted way of some clinics giving people what they perceive they want in terms of a blast off experience. There's no medical reason for it outside of just maybe getting some good reviews. But it's the recklessness of it and the disrespect for the medicines as a whole, like, is something that, really deeply bothers me as well.
And what I want to say too is that I have heard from patients, because sometimes people will call me, after their experiences in certain places, and they'll tell me that they had, they had a bad experience. And, it's just not acceptable. It's going to be rare. You won't hear a lot of them, but, nobody should be put into harm's way.
Yeah, agreed.
Well, I think clinics are touting it too as like the psychedelic all-you-can-eat buffet, right? And that's dangerous in and of itself.
It's recreational.
Yeah.
It's not medicine.
No. And
No.
Ibogaine's such a profound experience. I mean, you need to be with that,
Yeah.
Yeah. All right, let's take a question from Emma. So she says that is what you're describing regarding dopamine hijacking and drug addiction and dopamine deficiency similar for any other addiction such as food or sex? Would love to hear your perspectives on working with Ibogaine or Iboga for addictions other than just drugs.
It's a great question. It's a fundamental question. It's a great question. Thank you for asking it. We just don't know. We don't know. Food is very complicated because food is not, obviously there's a dopamine component to eating. Food is reinforcing, but there are other pathways that regulate food, calories, how our body adjusts to nutrient dense food, and how we get into maladaptive patterns around food. We don't know. We do not know, and we don't have sufficient evidence to suggest it. Is there anecdotal information out there? There's some. And certainly in the addiction space, often you'll especially working with some women and men too, that there will be eating disorders that are reported in the context also of addiction. Some women who are using opiates have had, fought food, anorexia and whatnot. The problem is that, especially for anorexia, I would be very frightened to give Ibogaine to a patient who was suffering from anorexia. Why? Because anorexia can cause damage to the heart. And Ibogaine is, we didn't mention that, is one of the worries about Ibogaine is that Ibogaine, unlike other psychedelics, which have very large, therapeutic to toxic windows, Ibogaine has a smaller one. So you have to be cleared medically. You have to be, you only want to have Ibogaine administered by clinicians and people in clinical settings where they have knowledge of the investigational nature of Ibogaine as a drug product.
Can you both speak more to that? Justine's asking about the risks associated with Ibogaine. So physical, mental, emotional, like what are the other things that we mitigate to create safety?
Yeah, Laura, I'll take it. As I mentioned about the psychiatric risk, I believe it's very low, especially because you have to screen patients. Okay, one of the most important things is when patients want to engage with a clinic, they need to be undergoing an interview. They need to explain what other drugs they're taking. They need to talk about other, psych meds that they may be on, and all medications that they may be using. Because again, I mentioned that Ibogaine is metabolized through the liver, so this sets you up for drug-drug interactions. So you have to be considerate of that, because you can magnify the possibility of an adverse event if you don't understand the nature of the drug interaction. Okay, highly metabolized drugs have more drug-drug interactions that can be adverse. The other thing it's the one thing about Ibogaine, I do believe that Ibogaine is a safe drug and that it can be developed for use as a pharmaceutical agent. And that's been my mantra for over 30 years. And I believe today we're seeing that come to fruition with those initiatives in Texas and elsewhere. And there's a study also going to open in Israel. And so this thing is going around the world now. The cardiac safety is extremely important. If you have cardiovascular risk, it needs to be fully disclosed, and you have to talk to clinicians, because you can be at risk for an arrhythmia following Ibogaine. Ibogaine is what we call a QT prolonging drug. It affects the refractory reserve of the heart, and it's a transient effect. It normalizes, it goes away, but as the drug reaches its maximum concentration in blood, you can be at risk for an arrhythmia. So you need to be in a clinical setting that works and understands how to prevent that from happening. And there is a risk mitigation strategy, and the clinics that are well equipped and knowledgeable know how to handle it.
That also involves emergency trained doctors, ACLS protocols, and proper screening and care.
And this speaks to why it's important to do this in a clinical setting, where Iboga can be worked with psychospiritually because it doesn't have the same concentration of Ibogaine. It's one of many alkaloids in Iboga. Ibogaine has this risk that can be mitigated in the right hands. So
I would still go out on a limb here and say that Iboga, you need proper screening too. So yeah, you need cardiac screening, liver enzyme test. I mean, it's important. So yeah.
I worry about it too, Laura. I'm with you on that. Many patients come to me and say, I want to work with, I want to work with the plant. I don't want to work with, purified Ibogaine hydrochloride in a clinical setting under medical monitor. I want to go, and I have this, medical problem. I just had someone reach out to me just in the last 48 hours who has a particular disease, and they want to do the experiment themselves with the extract. And I wrote back and said, I can't advise this. I can't encourage you to do it for all of the above reasons, but also, what are you taking? It doesn't come with a package insert. You don't have a certificate of analysis. And I can tell you, having done some, there was a wonderful paper published by the group in South America and their collaborators in Spain, and they took a bunch of Ibogaine, so-called Ibogaine and TA, the tincture, and other crude alkaloid products that they bought off the internet, and they analyzed them, and the amount of drug in there and the impurities were off the chart. So it's a buyer beware situation.
So we have a question from Ash around aftercare. Speaking specifically to, is there a need for opioid maintenance medication, for example, naltrexone, methadone, with proper aftercare? Laura, you want to take that one? You're shaking your head.
I mean, Ibogaine is it's no, I mean, it's more about doing the proper aftercare, having the therapy, the support, addressing the addictive structures, addictive patterns, and addictive behaviors. It becomes a counterintuitive process for you to go on naltrexone afterwards. I mean, for severe opiate relapse, we have seen in the past that about a week after your last Ibogaine dose, people can take Vivitrol, just as a safety net to really protect so there's no overdose, or it kind of, takes the personal responsibility part out of the piece. But I think a big piece of this is the personal accountability and being willing to change your life and having the proper support in place for when you get home. Again, Ibogaine is not a cure, it's a catalyst for change. But no, it's and another thing, Ibogaine is not a maintenance drug. It is not something that's meant to be taken over and over again. We also see a lot of clinics out there that are sending people home with follow-up doses, which is completely unethical and unsafe. I like to tell clients too, it's if a doctor is willing to send you home with a Schedule 1 drug, you have to question what kind of doctor this is, because this is illegal in the United States, and if you mix it with something that it interferes with, you could die. So it's about the proper aftercare and support of, therapy, addressing the underlying issues at hand that have led to the point of active addiction, and even trauma, like really like coming to terms with helping like close the trauma loops, working with somebody for EMDR, somatic therapy, really processing that unconscious material to make it conscious so it's not running your life anymore.
So in 2018, I published a paper from 191 opioid and cocaine dependent patients that went through the St. Kitts Healing Visions Institute for Addiction Recovery program that I started in St. Kitts. And what we know is that you are detoxed. All right. So back to the opioid question. You are detoxified from your drugs, whether it's psychostimulant or the opioid. So you are clean. Now, the question about going back on to Suboxone, buprenorphine, or methadone, normally, you would not do that because it is a transition to abstinence-based therapy. For some patients, as Laura said, who, you're clean, and if you leave Ibogaine and you go out and you use, you may not know your level of opioid tolerance, and that could put you in harm's way, right? So there are some people in the medical field who believe that you can't take patients that you have off of an opioid, that you have to keep patients locked in to maintenance therapy, whether it's with methadone or with Suboxone, for a long period of time because of this risk of relapse and accidental overdose. Okay? That is indeed a risk. We're not going to diminish it. We're not going to say that it's not a risk. And for someone who may be at risk, the possibility of using naltrexone after Ibogaine may be medically indicated. But again, this is why it's so important to be working with an ethical group of clinicians in a well-qualified clinical environment to help you make those decisions. All right? Because each individual may be in a different place in terms of their recovery. Now, at Demorex, we're developing noribogaine in a low-dose formulation in a pill, patch, or a depot so that we can maintain the window of neuroplasticity, and it's a non-addicting alternative to methadone and buprenorphine. But it's going to be many years before we're able to, get it to a place where it would be an approved drug product. And what Laura's talking about, taking small doses of Ibogaine what you're doing is you're doing a prodrug dosing to noribogaine, because when you take a low dose of ibogaine, it completely gets converted to noribogaine. These are experiments you don't want to do with yourself. No. Laura?
Agreed. Agreed. Yeah. Yeah.
Well, we have a question that actually piggybacks on that, what you're mentioning. Kirtan is asking, how long does the neuroplasticity rewiring period after the experience last? Does
That
it
is
vary from person to person?
that
Yeah.
is such a good question. These are, by the way, everyone, these are great questions. Thank you. You're hitting on the things that we forgot to mention. The window of neuroplasticity, yeah, and I'll let Laura will tell us from a personal experience, but the what we don't know the answer to that, and we don't know the answer to that for all of the psychedelic meds. Okay, they all open up the window of neuroplasticity. They're a little different by class of compounds, but what we know is noribogaine is the most potent, and it has the most profound window opening of all the psychedelics. It's very good, excellent scientific work done by Professor Goldolan, who was at Johns Hopkins University and published really the seminal paper on this. And she did this in an animal model, but what she was able to demonstrate is what we know from ketamine. Ketamine is a couple of days, which is why you need to have six treatments over a period of time. MDMA and psilocybin, a couple of weeks. LSD, probably 3 weeks. Ibogaine, wide open at 4 weeks. Laura, how long does it stay open?
Yeah, I mean, I'd say, typically we see like 1 to 3 months afterwards. That being said, like if you're not introducing new substances, you're actively engaging your frontal lobes, you're actually doing the work on yourself. I don't believe that it just switches back to no longer being within that time frame. Like I believe if you're actively doing the work and cultivating a personal practice with it and not introducing new substances, that you continue to build on that.
That's that window of opportunity of like taking the rebirth, the new foundation that this medicine offers and building upon it. And the choices we make determine, a lot of that, the length of time with the afterglow, if you will. So yeah.
Rewriting your personal narrative. Who am I today? How do I relate to the pro-social effect of these molecules, the ability to find your place in the world. And this is how it's used in Africa, right? It's used, I called it a chemical bar mitzvah way back when I spoke to Nina Diamond in an Omni magazine article. That's you become, it's pro-social in the sense that you find yourself as an adult and your relationship to the world around you.
I think that's also part of like the drug seeking behavior a little bit too, of like when is it going to wear off, right? And so you can feel like that the noribogaine slowly starts to decrease in your system. However, your brain stays reset as long as you're not introducing all these different substances again. So that's the personal accountability piece too. That's the commitment going into ourselves to the medicine, right? So it's not supposed to be that you're just blasted with noribogaine indefinitely, right? That would be another crutch. This has provided this time, this window of opportunity to really help me change and step outside the cycle. And you definitely feel the antidepressive qualities, the anti-anxiety qualities, right? But it's giving you that footing to establish yourself. This, again, is not maintenance. It's not, let's just keep taking more because this is going to run out soon. It's how am I going to change my life to support me every day moving forward, to consciously co-create my own reality.
Well said.
In your narrative.
Yeah.
So in that same vein, or similar vein, we have a question about what are the potentials for ibogaine to treat and prevent dementia and other brain diseases, knowing that depression, etc., can be precursors for dementia. Dr. Mash?
Deborah.
Wow, that's such a good one. That's such a good one. Well, obviously, or not obviously, nothing's obvious. There is excellent work done by my colleagues at Stanford and Nolan Williams and the groups that looked at veterans, and our veterans, coming back from Operation Iraqi Freedom and Operation Enduring Freedom, many of the men and women who had these multiple deployments sustained brain trauma, right? And so, and then also the PTSD, because they saw so much horror, the PTSD syndrome, as well as the trauma of, blasts going off around your head and explosive devices. Some of our jet pilots who, experienced G-force, little traumas to the brain and changes in, all kinds of things that could go wrong in terms of your vascular system in the brain. So what we've learned about this is that Ibogaine seems to be kind of really great at helping to reset some of the brain trauma. And this is the work, it's just emerging, it's emerging science now, that and done with functional neuroimaging, which again is coming out of the Stanford group at their neuroimaging lab there. And there's some other work, but a very limited work. But it suggests that that it may have some efficacy. And I think that some of the pharmaceutical companies are looking at psychedelics, as all psychedelics, as a potential for possibly staving off the development of dementia, especially in patients in the earliest stage. So when we call mild cognitive impairment, or MCI, as kind of the first diagnosis that a neurologist would make, looking at an aging cohort. So someone's starting to show early symptoms, which may suggest that you're on the trajectory to convert to a diagnosis of Alzheimer's disease. Not everybody with MCI, mild cognitive impairment, will convert, but a large percentage do. Can you use Ibogaine, noribogaine, or any of the other psychedelics to change that trajectory? And I, as someone who's aging, and if I had that diagnosis, I would definitely be very interested in this. And I know that Paul Stamets had been, I don't know where his study is, but there was a trial that was starting with a stack, which was psilocybin, niacin, and lion's mane. I believe it was lion's mane. And they were doing some work with that. So stay tuned, because I think we're going to learn more about this. And definitely, boy, that would be fantastic too, if we could learn if some of the psychedelic medicines could be used in stroke victims. For example, the short-acting DMT molecules may have some benefit in early stroke recovery. So that this emerging field in not only psychiatry, but neurology is very, very exciting, very exciting.
I think it speaks to the two probably greatest epidemics that we face as a global culture are addiction and dementia, or cognitive impairment across the board, how nature is always responding. That she has these medicines available, that if we respect her and are willing to do the work associated with this kind of healing, it is absolutely possible. I don't feel like nature's not responding to the suffering that we're going through. So yeah, that was beautifully expressed, and it's really very hopeful. Yeah. So, okay, we have questions. If either of you want to touch this around the fact that, Ibogaine's in the news in the US, $50 million from Texas and money from Arizona recently. Do either of you have any perspectives on what might be happening in the US, and where's your focus just in terms of where the most benefit can be placed in the short term, knowing that the US doesn't really play a turbo game necessarily with these things, but do either of you want to comment on that?
Laura?
I mean, right now, my focus is on Bassé in Mexico and really cultivating the most healing program that we possibly can. I think with the United States, I mean, it could go either way, right? Kat, me and you talk about this a lot. My fear is that, it's not done properly, and that, Ibogaine doesn't see the light of day because of that. And it has to be properly trained, professionals, emergency doctors. And, I mean, I believe that it can work, But part of me is also scared about, the perversion of this medicine. What is this going to cost long term? If and when a death happens, does it basically push it back into the underground? So right now, my focus is on Mexico and Bassé and developing, the holistic program to support my medical program. And how can we really make an impact in the client care from modern medicine, ancient solutions, and really support that as a new paradigm and model for healing.
So we're
Dr.
not waiting for the US to get their shit together, is what you're saying? Yes, I like that. And I would add too that, the healthcare system is so broken that even if this were readily available in theory, it wouldn't be to the majority of people for at least a very long time. So yeah, I echo the advice to not wait until the US gives a green light. There are places where it's already available.
I want to chime in one more thing really quick. My other concern with the US is just inflicting more medical trauma, and that it's not done in a proper way with like true care and reverence to it, and that we end up traumatizing more people than we end up helping. We see that a lot in the ketamine space too, people that don't actually have awareness of how to properly work with these medicines. And it becomes just more trauma for people instead of something that is truly healing.
And then the plant gets blamed. Like, yeah, I've got plenty of those clients in my integration coaching practice that are traumatized not by the plants, but by the lack of experience and understanding of these medicines from those who facilitate. So, yeah, that's an excellent point too. It's
I
complicated.
think I think there's a, this is an important time for Ibogaine. And, for me personally, I I fought this battle for a very long time. I stood up, in front of the FDA back when no one did, with very naively thinking that everyone would want this, that if they knew what I knew or saw what I saw, that they would want this. And the FDA was collaborative and helpful, and they worked with me. And then Howard Lutzoff had a death. Okay. And, these kinds of things will set the clinical trials back. The FDA is responsible. They don't want to stand up in front of Congress and say, we approved a medicine, and then there, are a host of bad outcomes. So it's very important that this proceeds. And as I used to argue to my colleagues and to people in the press and whatnot, that it needed to be done in an academic medical setting. And I believe in Texas that will be the likely outcome, that if the Texas initiative goes the way the RFP is written, and to be seen, because we don't know, that the clinical trials will be done, and they will be done safely. So I think the safety issue will not be there. What Laura raises is, what is the best practice? And she talks about medical trauma. That's right, is that we know the importance for these classes of molecules, that the setting, the people, the clinicians administering, the support staff, everyone, there needs to be an alignment here. And there needs to be some understanding about the power of these molecules. And they have to be administered by people. I used to say, if you don't arrive at this working with these drugs from an authentic place, you're bringing a bad energy into the environment. And those of you who have worked in other settings with plant medicines, no, you've taught me. I have learned from others who have done this and have done it successfully. I hope that this knowledge is communicated to people who are gung-ho to bring Ibogaine out there, and that it's done from a place of authentic healing, if you will, and so that we don't subject patients to further medical trauma, and that it is recognized to be a catalyst for change, that it is an addiction interrupter, it's not a cure, and that we have to give patients something after Ibogaine to help maintain the window of neuroplasticity through integration coaching and the right type of people who have the peer-to-peer experience with Ibogaine. And that's why some clinics, including Bassé, which is trying to set itself up as a premier Ibogaine clinic, is developing best practices and quality of care continuum that can be, translated for use of this drug going forward. And we all should pray that this is manifest. There is risk.
Amen. Absolutely beautifully articulated. Other question from Marta. She wants to know if there's any microdosing potentials. Is this a medicine that people can have incredible experiences with in smaller doses?
Microdosing Ibogaine is converted to noribogaine. I said that. Let me say it again. You microdose Ibogaine, it's converted to noribogaine. The microdosing, you don't know your metabolite, you don't know whether you're fast, slow, or intermediate metabolizer. Noribogaine has long half-life. How are you going to microdose it? What's the schedule of microdosing? Are you going to accumulate too much noribogaine? Noribogaine also affects the heart. So again, it's not mushrooms. Mushrooms are very safe. Microdosing psilocybin is not going to hurt you. Okay? LSD, very safe. Not saying you should go out there and microdose LSD. I'm not saying that, but I'm just saying it's very safe. I don't know anything about microdosing LSD. Some people are doing it. But with Ibogaine, noribogaine, wow.
And you got to be careful what you have in your system too. It's not safe. I'm going to stand behind Ibogaine is never safe to take unless medically supervised. Yeah.
I have that. That's on a tattoo on my arm somewhere. Actually, I don't have any tattoos, but if I had one, it would say
Like
take
glows in the
Ibogaine
dark.
under full medical monitor.
Especially to what you both mentioned earlier too, that anything that we source on the web or elsewhere in the underground with this is likely to not be what we think it is anyway. So yeah, that's clear then, not safe. Thank you. What about the preparation process? How strict is preparation for ibogaine in comparison to medicines like ayahuasca? Aside from, I think you named pharmaceutical contraindications, obviously, are there other ways in which we have to prepare properly to have a safe and effective experience with the medicine?
Again, communicating with the clinicians that are going to oversee your treatment is extremely important because you do need to titrate off of active central nervous system drugs and other medicines that you may be taking for, an infection or, some other condition in your body, or if you have diabetes or, whatever thing is going on with you. So it's really like a soup to nuts in terms of medical clearance, not to be underestimated. The other thing that's important, and if you're abusing drugs and alcohol, you probably haven't been taking good care of yourself. So your gut biome is a mess. You want to start to prepare for this, and then also it's very important that your electrolytes are tanked up. What are electrolytes? That's your sodium, your potassium, your calcium, and yes, your magnesium in your bloodstream. And that's something that patients need to be aware of. In Africa, when they administer ibogaine, they eat a lot of plantains. Okay, why is that important? Because plantains have potassium, and ibogaine and noribogaine are potassium channel blockers in the heart. So how clever that the use by people in Africa somehow figured that out, that you want to tank up your potassium level. So again, working with your doctor, preparing for the ibogaine treatment is important. Laura?
We're feeding plantains at every meal. Yeah, I mean it's different than, ayahuasca and the preparation, but I think a big piece of it too is like, really getting clear with yourself on why you're coming. I mean, it's a commitment. You have to feel the call. You have to be ready for it. It's not something to squeeze in between a trip somewhere. It deserves the time and space, and it's actually a deep calling. And also, I want to emphasize too, like, especially with the work we do, we don't treat this for psychospiritual. Like, this is a medically based treatment for us. So, it's not just, I want to take Ibogaine. And there has to be, because Ibogaine does have risks, like the benefits really have to outweigh the risks here. And yeah, it's really preparing yourself and setting the tone ahead of time too for when you get home, right? Like, do I have a few days off from work at least, right? Not just I get off the plane, I'm back at work and just back to the daily grind. It's really, I like to tell clients too, it's like, act like you just got out of surgery, right? Like, be gentle to yourself, really like take that time to come home to yourself again. So, but the preparation process, yes, like having, proper support too, and therapy, and, we do a psych evaluation and to like really help you prepare and get ready for it.
And I want to echo what Laura said. Benefits need to outweigh the risks. This is a drug that has risks. It's not psilocybin mushrooms. And if we learn something from the ayahuasca practitioners, they, the diet and preparing your gut and getting ready for taking ayahuasca, which, has two, multiple actives to make the DMT get up into the central nervous system. I mean, we learn something from that use, sacred use of ayahuasca, which is to prepare. And again, helping patients prepare for Ibogaine is extremely important. The other thing I want to say, thinking, and I'm so glad you said benefit risk, Laura, is that this is something that we all need to be cognizant of as people who are helping to educate others, because everyone on this Zoom is helping to educate others. You're part of the dialogue of working with these molecules, and it's extremely important. You're citizen scientists. You're out there talking to people. You're talking to patients. You're talking to people who may be thinking about doing these types of drugs. It's with all the buzz around Texas and Arizona and, money here and money there. And, oh, Ibogaine is, this, magic bullet for everything. People will want to experience Ibogaine. People will go into, unsafe settings to do Ibogaine. And we don't want that. Oh God, we don't want that, because that's exactly what set back Ibogaine for decades. So again, all of you, thank you for being here today and listening to this and getting the word out, because you're really helping to protect and ensure that people who are desperately in need of having proper access to molecules at retreats, in medical clinics, whatever settings, that they're given with high ethic, with qualified individuals who understand the power and the medical use. Thank you.
This is precisely why you were studying it back in 1993, and here we are in 2025, and it's still not accessible, is because it happens in spaces that aren't safe, and then every advancement gets pushed back, and everyone suffers because of it. So yeah, safety first. Absolutely. Speaking of which, I don't know that we covered all the potential side effects. Somebody is asking, are there any other side effects other than we're talking the positivity of neuroplasticity and all the things in that window of opportunity? Is there anything challenging physically or mentally speaking in the after effects of Ibogaine?
The adverse events that some patients will experience some nausea. That was one an ataxia of gait. You can't walk around when you're under the full visionary phase of Ibogaine early after drug administration. That's all transient. That's all gone. By 24 hours, you're back on land. So those are transient adverse events associated with the drug. Again, I mentioned that there's no persistent hallucinogenic effects after the Ibogaine is out of the blood, a half-life of Ibogaine in the blood, and the visions stop. So there's none of that. We did not see psychiatric adverse events in the cardiac, your cardiac system. The changes in the QT prolongation normalize as the drug leaves the system and as noribogaine leaves the system. So all of that can be monitored safely. And really, that's the, knock wood, that's what we've seen, and that is the main risk. So that's why, again, these transient changes in the body, the physiology is transient changes that can be medically stabilized when administered in a proper setting.
The one piece I want to add, it can be hard to sleep for about a week once you get home. So, iboga in Africa, they actually use it in low doses as a stimulant to go hunting. And so it's more like you're taking ibogaine naps after the treatment. Some people sleep right away, but I always like to tell people that it might just be 3 or 4 hours here and there at night for the first week before your system, renormalizes.
And one of the things that we know is that there are, and we've looked at this in animal models, and there are EEG changes in the brain, which are being reset. These are not animals addicted to drugs or alcohol, of course, but these are normal animals that have been used in a testing setting, teach us that there are some changes in the EEG effects, so which may manifest. Now, what we do know is that we've just completed a multiple ascending dose study of ibogaine in healthy noribogaine, excuse me, in healthy volunteers. And in healthy volunteers, we haven't reported top line results, but I can say today that there wasn't any sleep issues in that setting. So opioids disrupt sleep, okay, and that's known, and that's part of the withdrawal syndrome with opioids. So I think that in the opioid patient population, you're going to see more of that. But again, that's to be described in the proper clinical trial setting.
Excellent point about what opioids cause in the aftermaths. Last kind of combination question from a couple of people is just specifically, you were talking about the benefits have to outweigh the risks. So what are the core sort of conditions that ibogaine is best for, besides we've talked extensively about opiate dependency? And then someone's asking what's the oldest patient you've worked with? In other words, I'd love to hear, like, what are the qualifications? Like, is there an age cutoff? Like, are there other pre-existing conditions that prohibit someone from being a candidate?
Yeah. So the oldest person, I'll take the oldest person question. Obviously, the addiction, okay? It is a powerful addiction interrupter. It blocks, as Laura described and others have described, and is all over the internet, it blocks the withdrawal syndrome. It gives patients a gentle transition off of opioids. And this is extremely important because many patients have not been able to successfully detox from heroin or Oxycontin, buprenorphine, methadone, etc. So the ability to get patients off of opioids is a benefit. Yeah. Relapse prevention in the addicted population who's wants to make a transition to abstinence, that is a benefit. Again, as Laura described eloquently, you have to work with the molecule, you have to set the intention, you have to do the work, you have to swim when you hit the water. But if you do that, when the neuroplasticity window is open, you're going to have a phenomenal outcome. We've seen it again and again and again. Okay, so the best outcomes are those patients. So for addiction medicine, it's excellent. Now for PTSD, for trauma, MDMA just went up in front of the FDA, didn't get approved, but they'll be back up in front of the FDA with some revisions to their new drug application, no doubt, under the new administration, and we'll be working with the FDA. I'm certain of this. And MDMA, will be probably the first psychedelic to be approved, we hope, for the PTSD indication. So that's there. Other indications that are experimental at this time are not being advanced in the clinical setting. I think in Texas, they'll probably look for exploratory efficacy around PTSD and brain trauma because of their interest in working with veterans. But, again, the jury's out on this because we don't have enough clinical data yet.
Laura, anything to add?
I mean, as somebody that's received Ibogaine, I think that with trauma, it's definitely in a league of its own in terms of that as well. Just how you're able to see it from the third party perspective and close trauma loops and how it just allows you to process things in a different way. And then Dr. Mash, depression. I mean, noribogaine, it's just profound for that to really, have the ability to pull you out of that deep, deep depressive state. So,
and for drugs and alcohol, what fuels relapse is the profound anhedonia, the inability, that funky, deep, dark hole. When you talk about a dry drunk, what is that? Somebody, an alcoholic in early recovery, is white knuckling sobriety because you feel terrible, right? And the beauty of the Ibogaine noribogaine combination is that it does seem to reset that, and it is a rapid acting antidepressant. So noribogaine is a rapid acting antidepressant. We know this. And again, without overstating the clinical benefits, we're hopeful that the studies will demonstrate this. And certainly the patient narrative, so the patient data is not what the FDA looks at it, they explore it. It's important, it sets parameters, it helps us design clinical trials, but it's not until we get in the clinic and we demonstrate it, that we know that we've got, for example, Ibogaine, I'm just going to throw this out there, would have superiority over MDMA for certain types of traumas. We don't know the answer to that. Okay. Is noribogaine a better antidepressant than Paxil? We don't know the answer to that. Okay. So this is, I don't know that I'll be alive to see all these things happen. But that's where we're headed, and hopefully, all of the important work around Ibogaine that's done in really well-run clinics such as Bassé will help to inform, where the clinical trials are headed.
Well, on that beautiful note of positivity and hope, I just want to extend heartfelt gratitude to both of you, sharing your expertise and the hope that this medicine will be accessible to more people dealing with these really life-altering challenges. If any of you listening want to learn more about Bassé, you can go to bassaibogaine.com, and Laura will happily answer any questions about the process. Thank you everyone who showed up and contributed to the excellent dialogue, fantastic questions. And thank you for all of you being part of the Plant Medicine People community. We love you all so much, and we'll see you next time. Thank you. Thank you, Dr. Mash and Laura.